This free live webinar was recorded March 8, 2023, as part of the Canadian Neurovascular Health Society Education Series. This video is edited from the original raw footage. If you wish to support these live events and keep them free or at minimal cost for participants, you can do so by sharing this video, our website, our Facebook page, and or our Twitter site to anyone who may be interested. You may also make donations through Canada Helps or directly by e-transfer to Landon Schmidt, Secretary Treasurer, at landon@cnhs.ca. We greatly appreciate your support of our all-volunteer society. Donations of $20 and more will receive a Canadian charitable donation tax receipt. Join our email list to receive future event notifications by emailing Landon Schmidt at landon@cnhs.ca. Thank you. Welcome, and I'm sorry Dr. Yerlink is going to be delayed, but we can get going. So Dr. Haacke is well known to anyone who's been at our conferences and or seen our DVDs, and you're a friend of our society from, wow, I think 2011 you were in Sidney. I introduced you to that beautiful part of the country. I remember you saying maybe it was your first trip to Vancouver Island way back then. But you've been at the forefront of MRI high resolution imaging for so long, and you've been on such a journey in doing the forefront of this research, and so we're really looking forward to what you've got up your sleeve today and how you can enlighten us about where this field is going.
So it's a pleasure to be here today with everybody. I have many fond memories of meetings, not just in Vancouver, but in Ottawa, in Italy, and in many different places regarding multiple sclerosis and vascular effects. I hate to say this because it really dates me, but this is my 40th year doing MRI. So I'm going to share with you kind of some insights as to where we are today and how that might help better diagnose and better understand multiple sclerosis. Let me start by sharing my screen. And so the title of today's presentation is Applications of Stage and Micro to Imaging Multiple Sclerosis. These days, I'm affiliated with both the Department of Radiology and Neurology at Wayne State University, as well as a number of other universities around the world. So the major topics that I want to talk about today are multiparametric imaging of MS. And the question here is, how many sequences are really needed to image somebody, and what are the key biomarkers that you can take away from this? Another one is discussion of what are called ring lesions in relapsing remitting patients, and do they predict severity of disease? And a third one is a new technique we call microimaging, which is a means to look at the microvasculature, and are we able to see new findings for MS using micro? And can we possibly even see vessel wall inflammation? So the first presentation is on multiparametric imaging of MS patients, and this was in conjunction with AbbVie Pharmaceuticals, because the pharmaceutical companies, they also do a lot of imaging. And, it's in the past, it's taken maybe an hour of imaging to get all the information they think they might need. And one of AbbVie's questions was, is there maybe a shorter version of this that still gives all the information that we would need? In other words, are all these different techniques really necessary, and do they provide independent information? So that was the study we got involved with them. This was a number of years ago now. And we ran a method there called STAGE. So I'm just going to give you one slide on STAGE. Usually I give an entire technical talk on this, but we will condense this to a single slide. STAGE is a very rapid imaging technology. It's a method that we developed that can image the whole brain, actually in times ranging from 4 to 6 minutes. And if we add some conventional imaging on top of that, something called FLAIR, which you know, and DWI, then the total scan time to image the brain is 8 to 10 minutes. And that's a lot faster than what people usually do today. And if you've ever had an MR scan, then whether it's a volunteer or as an MS patient, you'll know that you're often in the magnet a lot longer than that. And what can we get from this data? Well, we can get quantitative biomarkers, not just pretty pictures. We can measure water content, which I'll show you in the third presentation, has some very important implications for understanding MS lesions. We can measure tissue properties, things called T1, T2 star, and susceptibility. And the exciting thing for me about pursuing this is that we can run this same technology on all the manufacturers' systems and basically get the same answer. And so some of the images that we acquire here at 3T are shown at the bottom, highlighting the different contrasts that are available with this type of technology. And I'll tell you a funny story, since this is an informal presentation. When we were imaging one of the MS patients and we ran this protocol prior to running all the other things I'm going to show you, we took the patient out after 10 minutes and brought him out and showed him some images. And he looked at that and he goes, "That's great." He goes, "Why did you bring me out?" I said, "Well, we're done." He says, "Well, you can't be done. They usually scan me for an hour. Put me back in the magnet. I want my money's worth." Now, that may sound funny to you, but it's actually a true story. MR is beginning to become so fast today that I can see we're not far away from having a 5-minute scan where you're in there and in 5 minutes, we basically get everything we need for a conventional clinical diagnosis. So multiple sclerosis is a neurodegenerative disease. It involves autoimmune components, inflammatory components. It's a progressive disease that starts off as clinically isolated syndrome and then can progress to relapsing remitting, secondary progressive, primary progressive, and then vascular dysfunction, and then finally leading to periventricular white matter lesions or hyperintensities, as they're called, as you can see in the image here on the right-hand side. So what's the purpose behind this talk today and behind this project? It was to better study the etiology of MS by looking at different imaging biomarkers. We wanted to image the white matter changes in MS subjects over 2 time points and evaluate the reproducibility of these various imaging methods in healthy controls and try to determine which imaging biomarkers provide the unique information for us. So we did 20 MS patients and 10 age-matched healthy controls. The MS patients were scanned twice, 6 months apart, which is not really long enough to see big changes. Probably you would have to do that over a 2 or 3 year time period in that case. And healthy subjects were scanned 2 weeks apart. They shouldn't be changing in 2 weeks. The disease duration for the MS subjects ranged from 1 year to 22 years, with a mean of 6.1 plus or minus 5 years. And the EDSS score ranged from 0 to 4, with the average being quite low, around 1.5. The different sequences that we used were what we call T1 weighted sequences. This is a T1 MP RAGE, then a T2 weighted FLAIR, and then magnetization transfer contrast, myelin water fraction, which is considered very important for looking at demyelination, SWI, and then stage that I just introduced you to, followed by a contrast agent, followed by T1 weighting post-contrast to see if there's any leakage of the blood-brain barrier, followed by a diffusion tensor imaging acquisition. So this takes a long time to collect this data. And those patients were in there for the hour, so they didn't complain how fast it was. And then the goal here is to look at multiparametric white matter imaging of the MS lesions. So here's some examples of the data that we get with all the different types of contrast. This is the original pre-contrast image, and then the post-contrast image that shows the blood vessels bright because of the contrast agent. And this is a T2 weighted image showing the lesions, but the CSF is also bright here, so we use FLAIR. FLAIR suppresses the CSF, leaving just the lesions very clearly visible. And you can see that they're periventricular lesions. And then we have the magnetization transfer contrast, followed by the Myelin water fraction. And in this particular case, we also have what's called a susceptibility map, which shows you the lesion here is bright, which we now believe represents demyelination. And if we look at the FA map, it also shows here a lesion that it has lower values of FA, meaning higher water content. And then cerebral blood volume map, a cerebral blood flow map, which doesn't really show very much, an MTT map, which stands for mean transit time. And then finally the ADC, which also shows that lesion. So we have a lot of different information here. What is really important in this information? So 18 of these subjects had 384 QSM positive lesions. That means that these lesions showed demyelination, and 94 negative lesions. 2 of the healthy controls also showed small white matter hyperintensity. The lesion count in the MS subjects varied quite dramatically from 2 in the lowest to 84 lesions in the highest. All lesions observed in QSM had a matching counterpart in the T2 FLAIR images, but not all the white matter hyperintensity images in T2 were observed in QSM, and those are the 94 QSM negative ones. One MS subject developed 2 new lesions over 6 months. The QSM positive lesions showed a mean susceptibility that varied from 0 to 85 ppb, and I'll talk more about that later. And the QSM negative lesions basically had 0 susceptibility. So what did this data look like? So let's plot all of these lesions. In this case, we're going to plot the properties of the lesions. So the T2 weighted images, as the T2 weighted images got brighter, so did the FLAIR images get brighter. So that's not a surprise. Actually, we expect to see that. And that was the same for time point 1 and for time point 2. Now, we can use the stage data to actually quantify different things, such as the water content and the T1 values. So here's a plot of the magnetization transfer contrast as a function of T2, and you can see that they are linearly related. The MTR plotted against the ADC from diffusion are linearly related. The T2 weighted images versus the water content are linearly related. Well, that kind of suggests that if I could measure water content, I can probably predict all these other things. Now, some more interesting plots here are the plot of the susceptibility. And the susceptibility is going to be positive if there's demyelination. And so here you can see in the open triangles, you have all the normal controls. They're beautifully bunched together. And then here are the MS patients. So you can see that some lesions have very high susceptibility, meaning they're very strongly demyelinated. Some of them only have very small susceptibility, so not so highly demyelinated. And it's now believed that we may be able to differentiate inflammatory-only lesions, which would be the ones that have maybe very low susceptibility, from those that are demyelinating lesions that have the very high susceptibility. We can also plot the 3 measures of diffusion. In this case, we plot the fractional anisotropy versus the ADC value and the relative diffusion RD as a function of ADC. And you can see these are all linearly related. So again, I don't really need all 4 of these measures. If I have one of them, I can predict the other ones. Now, probably the most important component here in terms of a special imaging method is called Myelin water fraction. So if the Myelin water fraction becomes less and less, so I have less percentage myelin, then what happens to the QSM values? And you can see here that, again, these are the healthy controls, or the normal appearing white matter in this case. And here are the QSM values. So the lower the myelin water fraction, the higher these QSM values become. And that's why I was saying we believe that by mapping out the susceptibility, we can say how demyelinated a lesion is. So increased susceptibility may correspond to demyelinating lesions, and lesions with less or no susceptibility, but that still show on the FLAIR images represent inflammatory only lesions. So maybe demyelination has not begun yet for those lesions, and that's a good thing. The average susceptibility for these lesions was about 50 parts per billion, and clearly very different than 0. The presence of lipid macromolecules such as myelin reduces the tissue susceptibility, resulting in an increased relative susceptibility in demyelinated lesions, whereas the other lesions with less or no susceptibility again represent inflammatory lesions. So all of these, MTR, T2, FLAIR, water content, ADC, they all correlated with the T2 weighted signal intensity, or they all correlated with this water content called proton spin density. T2 FLAIR showed the most lesions of all of them, with DTI measures being the worst because DTI has fairly low resolution. QSM offers the unique information on demyelination. STAGE offers the ability to quantify all of these tissue properties. And so the most efficient protocol, if you had to go in for a scan and you wanted to basically get as much information as possible, would be to do T2 weighted FLAIR, STAGE, PWI, and SWI. So in conclusion, MRI has a broad range of technologies and many, many different types of sequences. So if I go back for a minute and we just do T2 weighted FLAIR, STAGE, perfusion imaging, and SWI FLAIR, all of these can be done in 10 to 15 minutes, depending on resolution involved. So it doesn't need to take a long time. So in this studies, we demonstrated that we could basically differentiate demyelinating from inflammatory lesions, and that all measures had some component of correlation with water content. So in general, I think the take-home message here is there are some key pieces of information, the most important of which is differentiating demyelination from inflammatory lesions, and of course, detecting those lesions as well. Now, I'm going to do a very short presentation here on quantitative susceptibility mapping. So I'm going to focus a little bit on this because it proved so promising in the previous study. This was actually done with people from both radiology and neurology at Wayne State. And here I'm going to show you some example images where we have the normal FLAIR and T2 weighted images that show the lesions here. And then we have these susceptibility related images. And this image here, D, shows the presence of QSM or susceptibility values that are significantly different than the surrounding tissue. And this is called a ring lesion. It's believed that if you have these ring lesions, it's not a good sign. People think that these ring lesions change over time. And if you have them at the beginning and then they go away, that could be a marker for chronic lesions, that the tissue has actually been damaged in the process. So we wanted to try to identify the relationships between ring and non-ring MS lesions and correlate this to the EDSS score. And so we compared the total FLAIR positive white matter hyperintensity volumes with EDSS score. We compared the ring lesion susceptibility as seen with QSM with EDSS. And then we tracked these changes over time. And in this particular cohort, we actually scanned most of them for over a 2-year time period, not a 6-month time period. So we had 43 subjects who were included here. 41 of them got 2 more scans 1 year apart, so a total of 2 years apart. And this imaging protocol included FLAIR, pre and post contrast, T2 weighted imaging, and SWI. And so we could use SWI to try and look for these ring lesions or annular rings, and then compare those to the white matter hyperintensities. And what we found is that there was a correlation with the number of ring lesions with EDSS, but the lesion volumes didn't show this correlation. we found that the values of the susceptibility weren't as high as in some of the QSM lesions and stayed constant over 3 time points. We also found that the volume and diameters of these did not change quickly over time. So that means that the tissue hasn't really gotten worse or gotten better during that time frame. And we found that the FLAIR lesion volume positively correlated with EDSS. And basically that means if you have too many lesions, you're probably not doing as well as somebody who has fewer lesions. So we found that the ring lesions were chronic in nature. They were easy to detect using QSM, and that FLAIR remains a sensitive tool for looking at vasogenic edema. Part of the limitations of this study is that it was only, again, over a 2-year time period, and so we can't say what happens over a very long period in time. So let me stop there for a minute and see if we have any questions, Sandra, because we're about halfway through, so it's okay to pause for a minute and see if anybody has any thoughts or comments.
Yes, there are 4 that I've tracked so far coming in, Dr. Haacke.
Okay.
First of all, were any of these scans done using contrast medium? And do you know of any health implications about using contrast mediums that contain iron?
Oh, well, I'm going to talk about that next, actually. Okay. But the contrast that we normally use is called a gadolinium-based contrast agent. And you don't want to use that if you have compromised kidneys. So there had been a problem with the earlier contrast agents, the linear contrast agents, and they sometimes created some bad reactions for patients. Those have been changed to what are called macrocyclic agents today. And to my knowledge, they do not have that same problem that the earlier contrast agents had. So they're much safer to use. And the doctors still use contrast agents for many different studies. So if you're getting a macrocyclic agent, you probably don't have to worry. Those agents are important because they help you study the breakdown of the blood-brain barrier. They show whether you have an active lesion or not. So again, another reason why the radiologists will tend to do this, at least the first time you come in. They may not do that if they're going to scan you on a regular basis. They may not do that again for several years afterwards. But usually at the beginning, they will do that.
Good for a baseline. And so any of these scans, Dr. Haacke, inform whether relapsing remitting is transitioning to secondary progressive. Do those categories, I remember at one conference you talked about reimagining the categories of MS. I believe that was you that mentioned that in one of your previous talks. You know, so do any of this research fall into the categories that are traditionally used to name the different types of MS?
I think the imaging is not so much used for that as the actual patient's physical condition. So those are the clinical markers that the doctor uses to determine, you know, whether you have progressed from one year to another. You know, does your EDSS score change significantly? And then if that, you know, if your motor effects are worse, if any cognitive effects are worse, then, you know, they will denote that as perhaps having changed from relapsing remitting to secondary progressive. And then the effects have to be very severe, I think, for you to be called primary progressive. So I think that still kind of remains a bit of a gray area. You know, how can we predict what might happen to somebody? I'm not sure that predictive capability is there yet. Would be wonderful if, you know, we could monitor what's happening with the lesions. And, you know, today many people are taking a drug, right? So in that case, the drugs may be doing a good job stopping the development of the lesions. So clearly, if we saw a new lesion every time you got scanned, that would not be a good sign.
Yes.
If in this particular population, their lesions were except I think for the one person, their lesions were pretty much stable, which is great for them. It didn't look like there was any change over time.
Okay. All right. So this one I'm just going to read. So the person put in quotation marks, flow map doesn't show much. And then they said, what does this mean in relation to 2 of Dr. Zamboni's 5 criteria, which include flow reversal?
Well, yeah, I guess that depends. If you're talking about, he used ultrasound to do that.
Yeah. You
can do a very good job on this using MRI. So there you can measure flow in many different veins. You can do it in the jugulars, in the neck at C2, C3, and C5, C6. You can do it in the brain and measure the flow in all the dural sinuses. So that kind of gives you some measure of what the flow effects are. The problem with CCSVI and imaging the vessels is that, I can just give you my insight after all these years, is that there are a certain fraction of MS patients who really did benefit from treatment. But that might be a very small fraction. It might only be on the order of, say, 20%. And those people really did have obvious severe restrictions of the dural sinuses. But, nature is very complicated. You have to remember that we have 4 major arteries going into the brain, and then you have 11 venous pathways out. So that means that you could have a narrowing of, say, your left jugular, but the right jugular carries everything out. And you also have all the other pathways. You have what are called the anterior jugulars. You have the deep cerebral veins. You have the venous plexus of the spine. All those carry blood out. So, the body is very smart. It has all these alternate pathways out. Unless you're very compromised and you can't develop those collaterals well, and these other vessels are also not functioning, okay, that would be a severe case. And maybe, I'm just generalizing, maybe those are the people who benefited from the early treatments. So trying to quantify this is very important. And we have published a number of papers where I think we did as many as 500 or 600 cases and mapped out the flow values in those patients and showed what was abnormal flow. Now, I'm not talking about that today, but you can look up our papers, and there's a very nice chart there that shows if the sum of all the flow in the jugular veins is less than, say, 50% of the carotid artery inflow, that's abnormal. Not very many healthy people will show that.
Yes.
So there are quantitative data out there for this, and I would recommend you look at those papers.
Okay, and so this one, those of us who have sat through or laid through a 90-minute MRI, certainly we're excited about the prospect of shortening that time. How long for this technology to go into common practice at MS scans broadly?
That's a great question. All the manufacturers are pushing their different fast technologies. And on the newer scanners, these are becoming much more available. So part of this, whether or not you're in there a long time, depends on the type of scans that the doctors perceive they need. So part of our study was to show that, 3 or 4 of the scans that they love to run from a research point of view, practically speaking, may not really be making a major contribution to understanding the disease. And so if you're just in there to get a clinical diagnosis, it's possible, as I said, to do this, without a contrast agent, it's possible to do this in less than 10 minutes. With a contrast agent, 15 minutes.
Wonderful. And just could you repeat the contrast agent that you mentioned as a preferred choice? Oh, so for the gadolinium-based contrast agents, I think everybody today is using the macrocyclic versions of this. All right.
Macrocyclic.
And we're recording this, so you can always go back and listen to what Dr. Haacke's full response. So, and I mentioned Dr. Zvadanoff because the next question mentions him. This is Dr. Zvadanoff presented at ACTRIMS that his CASA MS study of severe MS matched with MS twins with equal demographics and disease duration showed that the severely affected twin had the same white matter lesion history and brain atrophy, but severely affected twins had much more damage in cortical, thalamus, and spinal cord in the gray matter.
Yes, I remember this.
Yeah. Can you explain the difference of white matter and gray matter lesions and why it apparently matters where the lesions are? And is the MRI technique different for both of those?
Yeah, that's a very good question too. So the problem with just white matter lesions by themselves, whether they're present or not, doesn't necessarily indicate how they will affect you. And so one of the things I'm going to show you a little later here is a new measure of water content in the lesion. So this helps us quantify what's happening in that lesion. And so the normal presence or absence of white matter hyperintensity may not correlate with patient outcome. And that's always been a problem that you know, the presence of lesions is opaque to understanding the clinical condition. But we are getting there with these different biomarkers. Now, you know, gray matter lesions are important, of course, for anything cognitive. So if there are problems in the gray matter, then that could have severe implications. So the white matter tracks, remember the white matter contain all the tracks that connect the different parts of the gray matter. So that if the white matter tracks are affected, that can also affect cognition as well, because the different parts of the brain are talking to each other. The question is, we just don't know how those white matter lesions are affecting that communication. And in some cases, although the white matter may be inflamed, it may not be affecting the communication. That's what we don't know yet. Okay. And that's where something called functional MRI is probably going to play a role, and diffusion tensor imaging may help play a role in understanding how the networks of the brain are affected. And so if you affect the gray matter, as Zvadanoff has noted, you know, that may be, you may be able to correlate that with clinical conditions if you know where that is taking place. So I think those are important areas of research.
Yes. And just the last one, have you ever seen, you said that the lesions are relatively stable, but have you ever seen reversal in the myelination? Basically, have you seen any evidence of remyelination with subsequent imaging?
You know, I don't personally have a study for that, but of course that's why they have remyelinating drugs, right? Yeah. And that's the whole point behind relapsing remitting. It means the lesions come, the lesions go. So, you know, you can have a lesion there one time and then come back a year later and the lesion might be gone. That's probably, I'm guessing, because it was predominantly an inflammatory lesion, and maybe there hadn't been significant demyelination. However, it may well be that, you know, mild demyelination can also recover under the right circumstances. I don't know the answer to that.
Okay. Well, that's our questions for this section,
okay.
Dr. Haacke. So thank you very much.
All right. Well, then let's continue with the last part. Well, this is a very exciting part. This is a novel approach that we are using a different type of contrast agent for what we call microimaging. One of my former students and former postdoc, who's now a faculty in neurology at Wayne State University, Sagar Bhutt, has really done an amazing job on this. So micro stands for microvascular in vivo contrast revealed origins. It's a new approach that lets us image all the vessels in the human brain on the order of 50 microns or bigger. And 50 microns is the thickness of your hair. So it's pretty amazing if we can image vessels that small in the brain. So we think that imaging the microvasculature is key to understanding the etiology of many diseases, including dementia, hypertension, MS, Parkinson's, stroke, traumatic brain injury, because it's very difficult to detect with conventional imaging vessels less than or on the order of 250 microns. Now, One exception to that rule is using SWI with very high resolution at high field. Here we have some data showing an in-plane resolution of close to 200 microns by 200 microns. And the interesting thing about SWI is it can see things 4 times smaller than a voxel. So here you can see all the medullary veins, which I believe are very important for MS patients. It may be that part of the lesions or the presence of lesions, as our old colleague Franz Schelling would have us believe, is related to abnormal flow in the medullary veins. And then we can see something that has become quite popularized by the neurologists and radiologists called the central vein sign using SWI. But in this particular image, the yellow arrow is pointing to a small venule that comes off of the Peel vein. Actually, in this case, goes into the Peel vein. And this venule is only 50 microns. So here's one, and here's one, and here's one. It's really amazing. This data is as good as imaging a cadaver brain, except we do this in vivo, and this is done with no contrast agent. So it's really very impressive scan. The question is, are we seeing all the vessels here? And the doctors, they don't want to just see veins, even though veins may be the most important thing for MS, by the way. The doctors also want to see arteries. So how can we see arteries? The reason we see the veins using SWI is because they have deoxyhemoglobin in them. So when that blood comes in, the tissue eats up a certain amount of oxygen, about 30% of the oxygen. So you have 70% oxygenated blood and 30% deoxygenated blood. And when you take that oxygen away from the hemoglobin, basically you take 2 oxygen atoms away from the iron and you have now unscreened it. And when that iron atom is unscreened, it develops a small paramagnetic susceptibility. And using this technique, SWI, that I developed, we become sensitive to the presence of that deoxyhemoglobin. So very exciting. That can be used particularly in stroke when you have reduced blood flow and you can see major changes in deoxyhemoglobin. So we proposed this idea. Let's use an iron-based contrast agent that can turn arteries into veins in the sense that they have susceptibility. So if you can change their susceptibility, we should be able to see them using SWI. Of course, our major concern in doing this is with allergies. Our major concern is safety, right? So anybody with allergies or low blood pressure or hemochromatosis or thalassemia, we don't use this contrast agent. But this contrast agent is FDA approved to treat people with anemia. So they use this with a much higher concentration than we use it in order to medically treat those patients with anemia. So in that case, you would use a dose of 7.5 milligrams per kilogram over a 15-minute time period. In our study, the maximum we use is 4 milligrams per kilogram, and we inject it over 20 minutes. All subjects are monitored for half an hour after they come out of the magnet. We always have a nurse or physician present while we're doing this. And to date, we've done more than 60 cases, and they've all been scanned without any ill effects. So we've had no complaints of things, whereas sometimes when you get, normal gadolinium, people will come out and say they had this metal taste in their mouth.
Here comes Dr. Haacke back in again. I'm
very sorry. We lost power here. It just came back. Let's go for it. Sorry about the gap here. And I was just about to say, I think I was going to tell you here that here now we can see all the arteries and the veins using SWI. This is pretty amazing. So these are 1.5 millimeter thick. All right. So these are pretty amazing results here. So before, all you saw were the veins. Now you see all the arteries and you see all the vessels inside the deep gray matter. And you have to remember that this is only over about 1.2 centimeters, a tiny little part of the brain. If we projected this over the whole brain, you wouldn't see anything. It would all be black because there's so much blood in our brain, right? So one of our challenges here is how do we separate arteries from veins? So we've been developing the technology to create these types of images where we can highlight the arteries in red, the veins in blue. And I'm not sure this will play. Oh, too bad. This is not playing. It's a beautiful movie that shows the separation of all the medullary veins from the rest of the tissue here, so we could focus on that, particularly for MS. And let me show you an example now of the difference between what we see with gadolinium versus what we see with this drug called ferumoxytol. And on the far left-hand side are the original images. And this is the T1 weighted, and this is the SWI. There's maybe a hint of something here, but I don't think the physician would have said anything. After contrast agent, there's a little bit of enhancement. And here you can see what we call a developmental venous anomaly. It's actually like a micro DVA. It's very small. And if you draw a circle around that, lo and behold, that's exactly where the lesion appears in the FLAIR images. So it's very interesting that this vascular anomaly correlates with the development of white matter lesion. Now, we don't see that in all these lesions because you can see this individual here has other lesions, but you can see what's called the central vein sign associated with that lesion. So the question is, why is that happening? And I will try to reveal a little bit of why that might be happening. So basically associated with the pathology in MS is endothelial damage and venous collagenesis, fibrin deposition in the veins, loss of vessel compliance, venous hypertension, reduction of blood flow, medullary vein dilation, and then local vascular remodeling. And I believe that DVA is an example of local vascular remodeling because there has been a loss of blood flow in that area. And then all of those lead to hypoxic ischemia. And this is a graph demonstrating that whole process. I may not have really time to go through all of this, except to point out that when you get narrowing and venous collagenesis, that this just basically is the beginning of a process that gets worse and worse and worse. And when you get vascular insufficiency, then this turns around into venous hypertension. It has this pulsatile flow and even the reverse flow effect that someone asked about earlier. And this then leads to extravasation of all sorts of things, particularly cytokines, which then causes more damage to the vessels. And eventually you have hypoxic ischemia, and then you have cell death of the tissue. So what can we see with this new method? We can see these small ovoid lesions that I'm going to show you. We can see vessel engorgement. We can see the developmental presentation of perpendicular vessels instead of the normal horizontal vessels, and then these venous angiomas. This particular slide is, I think, one of the most interesting. So now, by looking at a combination of the SWI and FLAIR data, and I'm going to focus on this case right here, you can see a small enhancement around this medullary vein. That's shown here in the cartoon on the left, where the blue represents this inflammatory effect. And we're now seeing this where we never saw these before with conventional imaging. And I do have one case of an individual we had been imaged over 15 years, who starts off with a small enhancement like this. And then over the next 5 years, that inflammation just grows all along here. 5 years later, it's a much, much bigger lesion, and it has the central vein sign. So one potential hypothesis is that we are looking at something called the inside-out theory, where there's a breakdown of the blood-brain barrier, cytokines and leukocytes and other things escape. They cause inflammation of the tissue. And the question is then, are we now detecting these early enough that we could predict the development of future lesions? Or can we watch these come and go? Now that brings up a big point. I didn't actually put it in the slides, but last year, there was a very important epidemiological paper studying thousands of MS cases. I think this was done in the New England Journal of Medicine, and it referred to, having studied these people in the military. And all these people had MS, and the probability of having MS was 32 times higher if you had Epstein-Barr virus. Now, those of you who have read the older literature in MS will know that people have brought up this question again and again. And so one of the interesting things is what we learned from COVID in the last few years is that COVID can create something called the cytokine storm, and it does it very quickly, right away. And it's thought to cause significant neurological damage in people. But Epstein-Barr virus stays with you for your life. It can be latent and not latent. And so the question is this a viral effect? Is this caused by Epstein-Barr virus? Is this something that is attacking your system over a long period of time, just to a lot lesser degree than COVID does? But could this be one of the culprits of developing MS? So I think that's a very important direction to pursue. And if we can monitor the presence or absence of these developing inflammatory regions, it may bring us a lot closer to understanding what's happening in MS. I'm going to skip through some of these. Here's another example of that developmental venous angioma that may be associated with poor flow in this territory. So similar to the one I had showed you before, yet another one here. Most of these other lesions are affiliated with central vein signs. And often this territory here is among the most affected territory. So now we're using this method we called STAGE to map out not the presence of just these lesions, but to measure how bright they are in this image called the PSD image, or the water content image. Because the higher the water content, the brighter the image will be. And I can measure that today. So if this is 100% water, that means there's no tissue left there at all. So we're talking about the ability to measure tissue atrophy based on this quantitative biomarker. And here's another example that shows a FLAIR lesion, and it looks like it has this ring associated with it, but it's actually not a ring. FLAIR suppresses high water content, which means this part of the lesion should have high water if I look at this PSD map, and lo and behold, it does. So this represents tissue that is probably chronic and tissue that has probably been atrophying locally. So a whole new measure now, not just looking at the presence or absence of lesions. And if we map out in the brain all the lesions and where they're located, that's shown in red. And you can see that these basically are surrounding the ventricles. That's why they're called periventricular. And the blue represents all those lesions that are abnormally high in water content. And you can see that those lesions are developing right adjacent to the ventricles. And this is, of course, where all the medullary veins come. They come into the ependymal vein, which is right above the ventricles. So in closing for today, modern MRI techniques really offer a means by which we can acquire new biomarkers that we hope will help continue to lead to new ideas for better understanding the etiology of MS. And these include the STAGE technology with SWI, QSM, and water content, and microimaging to study the microvasculature. And we've only done about 6 or 7 MS cases so far using this micro technique, but we've done about 60 or 70 healthy controls. So we really do have a lot of background data. And those abnormalities I showed you, we don't see these on healthy controls. We only see them even on those 6 or 7 cases we have done so far. So I'm going to stop there, and sorry for the delay in between. Any other questions?
There we go. There are a few questions, and so I'll just whip through them. About the trigeminal nerve, have you got any experience imaging that with regard to MS? And the question is to predict or follow the recurrence of MS related to trigeminal neuralgia.
No, I'm sorry, I haven't got any experience using these technologies there.
Okay. All right. So Andrew Katz would like to send greetings from Ottawa, and he's wondering if you have any opinion on the low voltage effects on the brain with regard to remyelination.
You mean the old question is, if you're living under the hydro lines, does it have any effect on you?
Yes.
Okay, so, I've been aware of these questions for like 30 years now. I don't think there's any evidence that that has any effect on people.
Okay. Can flow be measured using micro on vessels in the 500 micron to 3 millimeter diameter range?
Well, I am so glad somebody asked that question because I didn't show that today. So you might ask, how are we ever going to show that there's abnormal flow, say, in the ependymal vein, which probably is 2 to 3 millimeters across? The medullary veins are only around 200 to 300 microns across. So actually, we have just started to create some imaging that is about 250 micron by 250 micron cross section. And we've actually scanned a few normal volunteers to demonstrate that we can measure the blood flow even in those small vessels. And so it should be much easier to do that in the ependymal vein. We're actually quite excited to start to do that so that we can compare what is the normal flow in healthy controls versus what is the flow in the ependymal veins for those, especially for those patients that show a lot of white matter hyperintensities in this region right here. So if you can still see my slides, you see this thin blue strip?
Yeah.
That's right along the ependymal veins. So if we could demonstrate there's really been significant reduction of flow there, it may relate to the fact that there's Epstein-Barr virus, there's collagenesis, there's narrowing of those medullary veins. And so it's creating what we would call a venous hypertension effect. And yes, we're heading in that direction. So thank you for that question.
Well, while you were in your power outage, I said that you are akin to the James Webb telescope for the galaxies, that they're looking further into the universe than we've looked before. And you're doing the same on the microvasculature. So
yes, we're trying to get smaller and smaller and smaller. That's right.
Smaller. All right. Repeat angioplasty. Have you noted any subsequent improvements there? Have you ever recommendations I know are hard for you to say, but have you ever noticed whether repeat angioplasties could have any benefit?
Well, I think that's a very difficult question to answer for a few reasons. First, it really depends what was being treated in the first place. And, the problem with veins is that they're very compliant. They're not stiff like arteries. If you have muscles compressing the jugular veins, and that could cause a problem. This is a hit or miss perhaps with whether or not the angioplasties are going to work and whether they stay in place or not. In some cases, you may get lucky if you had some type of narrowing in an area where the muscles weren't having an effect, and you really made a significant improvement in blood flow. That might be something that's worth looking at. Some people, by the way, do you remember Marion Simka?
Yes.
Marion just contacted me last week and was asking me to give him some of our data on the blood flow into and out of the brain because they're trying to do some fluid dynamic modeling. And I don't know if you remember Tito Toro. Also, he's done a lot of work on computational fluid dynamics, and one of his students just spent 3 months with me. So both groups are starting to look at how can we predict what the effect of abnormal flow in one of those jugular veins might be, and how could that affect what's happening in the brain. So they believe that it's the upper level stenosis that could be causing the worst problems. But the difficulty is in the upper level stenosis, there's almost no way to enhance it because it's surrounded by bone. And so there may be no way to make it any bigger. So these still remain unanswered questions.
Well, thank you for, yes. And Dr. Simka, was at which conference? I think Saskatoon. He came out to Saskatoon. So do you know when this technology may percolate through to MS clinics? You said, is it being adopted at all?
So, there's two big parts that I closed on the last slide, right? One of them is using Stage, and we would be happy to help implement Stage at any site that might be interested in doing this. the lovely thing about it is it's good for the site because it provides them with a rapid imaging technology. It's good for the clinicians because it provides them now for the first time with quantitative data that they can really use. So that's a very easy implementation for us. I'm actually on my way to Montreal in 2 weeks to give a talk at the Montreal Neurological Institute. And I will talk there about Parkinson's disease, multiple sclerosis, and a few other major advances that we have made. And so they are also trying stage right now. And so I will certainly be showing them some of these results. So easy to implement. The micro imaging is much more difficult because it requires using that USPIO, which is not yet FDA, it's FDA approved, but not adopted in Canada yet. But I just found out that Canada is now going to accept the use of that drug. And so we've done it in Canada before in London at the University of Western Ontario, but we had to have a special permission to do that. Now that may become available in Canada. In that case, our whole technology is there. And if any of you want to read a little bit about this, I think all 3 of the major papers are published in a journal called Neuroimage. So if you just go to PubMed and type in the name BUCH and HAACKE, if you do Buch and Haacke, it will pull those papers up for you. And he's done a fantastic job on this. In fact, so much so that we're looking at measuring these small vessels in the hippocampus in vivo for the first time ever, with the idea of mapping out vascular density to see if we can predict dementia.
Wonderful. Oh my goodness. Yes. Here's one question with regard to the chart just shown, and I think it was 2 charts back. Could the internal jugular vein and the vagus nerve compression, often seen at C1, C2 in many neurological issues and disorders, be relevant? So looking at vagus nerve compression.
Yes, the vagus nerve, I know there have been a number of studies on this, even dating back, I think, to the 1920s and 30s, some early work in that direction. That's, of course, possible because of the autonomic system. The jugulars are thought to affect a number of diseases. I remember there was a lady, I think her name was CHIH, something like this, from Taiwan, who presented a lot of work related to other diseases, even dementia, saying that there were these vascular flow irregularities. And so we had invited her to many of the CCSVI meetings because she presented more than just MS as having problems on the venous side.
Well, I mean, when you talk dementia, it transcends illness label, doesn't it? Like, you've got cognitive issues on many disease fronts, and the science of disease labels are sometimes confining to those of us who fall outside the boundary of a strict one label fits all, right?
Yeah, now I have an interesting story that relates to that. So apparently about half of Parkinson's patients go on to develop dementia as well. Mm-hmm. And so, we are very interested in that. That's why I'm collaborating with London. But we also published a paper many years ago showing the presence of CCSVI in Parkinson's disease, and that it in fact is much higher than in normal people, maybe not as high as in MS. And there's an interesting story that we scanned somebody many years ago, probably 10 years ago, who had MS, and they had very irregular veins. And it turns out that their sibling had Parkinson's disease. And we scanned them, and they had the same very irregular veins. So it made me think at that time, maybe I should also do that on Parkinson's disease. So yes, you're right. This could be something unique that people just never looked at before. Now, we have to be careful not to generalize this, because Parkinson's disease is really Parkinson's syndrome, because there are many types of movement disorders, just like MS is really a syndrome. There are probably many sources of MS, not just Epstein-Barr virus. but that's obviously a big player. And so you can't assume that, one group that has, say, CCSVI is representative of the whole population. That CCSVI may only be relevant for 10 or 20% of MS patients. And that may be true for Parkinson's. But the point is, those 10 or 20%, if that's really the case, that's very important for them.
Very important. Yes. Yes. All right. So just one, with regard to high intracranial pressure, from issues like compressed internal jugular veins, doesn't it shut down the lymphatic system too? Is that not relevant with Alzheimer's and Parkinson's as well?
Well, I think that's a very hot topic today, the studying this flow in the CSF and looking at the lymphatic system. It's really opening up for a lot of research and a lot of questions. And people have shown, even in Parkinson's, that they think the lymphatic system is behaving abnormally. So whether or not, the jugulars cause changes in intracranial pressure, because it's believed that it doesn't cause big changes in intracranial pressure, unless you had a completely blocked, as in, I'm trying to remember the name of this, one of the hypertensive diseases. Sorry, it slips my mind. Idiopathic intracranial hypertension.
ICCH, that one, yeah.
So idiopathic intracranial. So IIH. That is related to having a almost completely blocked transverse sinus, for example, or people who have, venous occlusions. Of course, that will cause increased intracranial pressure because, blood can't get out. So that's creating a very serious problem. But if you just have a stenosis, and as I said, you have 11 pathways out of the brain for the venous blood, then, overall, that may not be a major problem. Again, I think there's some work by Marianne Simka and a few other people in the ISNVD who've done work on that, trying to measure those changes. And I think they're not very big changes.
Yes. I mean, do you ever measure mean transit time through the brain, the blood flow? Because even though you're saying there are alternate pathways out, if the blood is taking longer to get from ear to ear, basically, to come out.
Yeah. Well, I mean, think about it. If somebody has a completely blocked left system, all the blood from the brain has to find its way out the right side. And generally, it does. If it does, that person is probably not doing too badly, but nevertheless, you have a system with increased resistance, right? And so it's going to take longer to get that blood flow out. And that over a period of 10 or 20 or 30 years, that might lead to late onset MS, for example. Yes, when you do perfusion imaging with contrast agent, we measure cerebral blood flow, blood volume, and MTT. The MTT is actually the most sensitive, the mean transit time, and it's used in stroke all the time to map out any flow abnormalities. So yes, I highly recommend that if you are getting a contrast agent, you make sure they do a PWI scan. It only takes like an extra 2 or 3 minutes.
All right, so the last question then, any tips to improve blood flow from your vantage?
Well, that's going to be a very interesting question. If we find that there are local, now remember what I've been talking to you about today is kind of the very opposite end. As Sandra said, I'm kind of gearing up the microscope to look smaller and smaller, right? And so, CCSVI was all about major dural sinus effects. I'm talking about effects at the level of the medullary veins. And this, the neurologists probably would believe, unlike they, didn't like the other concept. But I think they have a lot of belief that a lot of this is coming from the venous side at the level of the medullary veins. And that's why the central vein sign is so important to them. And, how do we increase local blood flow? Well, first thing is we have to find out where the source of that is and what's causing the source of that. And if it is Epstein-Barr virus, is there some way to prevent this from developing? I mean, to me, if I were a drug company, boy, I'd love to know that. And that's one part of the story. Stop it from happening, right? The second part is, what if it's already happened? You know, what could you do to help? Well, again, probably the best thing is to stop it so it doesn't get worse. But whether or not we could improve local blood flow at the level of 250 microns, that's tough. I mean, I think what nature is doing is nature has developed those venous anomalies because it can't get the blood out of that medullary vein anymore. So it creates all these other pathways in its effort to get the blood out of there. That's it. That's nature's way to do it. Yeah. So I'm not sure how we would do it at that micro level, but I think the best thing is stop it before it happens.
Well, on that note, we're getting lots of thank yous here for your presentation today, and you know, thank you for persisting through your power outage. I hope that it wasn't.
No, just temporary.
Yeah. Well, thank you so much, Dr. Haacke. And now, for those people that want to review, I said all of this will be available. And Dr. Haacke, with your permission, we will put your full presentation in the recording. So the slides that you skip through quickly. Sure. Don't mind, would that be all right?
Yes, actually, I did change it since I sent it to you. So I'm going to send you an updated version of the slides, and you're welcome to share these slides with anybody, okay?
Thank you. And also that little movie that you couldn't get to play, we'll play with that and try to get that to play in the recording as well.
Yeah, so I do want to tell you that the cute thing about that movie is that when you play it, assuming you can play it, and I hope you can, is this, we call this the vascular tree, right? It's all the blood vessels. But I actually sent this out as a Christmas greeting to everybody, because when you play it, you're going to find this flashing lights of the vascular tree. So it was my Christmas vascular tree that I sent to everybody.
Lovely. Well, we'll try to place that in the recording as well. Okay. So thank you so much. And, you know, we will look forward to hearing these developments as you go forward. And I know you'll keep us informed, but, you know, just great gratitude from our community here today, Dr. Haacke.
Thanks very much. Very nice to touch base with everyone again. Thank you.
All right. Take care.
Okay. Bye-bye.
All right. Bye-bye. If you appreciate our efforts here, please donate if you're able. If you're not able to donate financially, we do appreciate you sharing our webpage, sharing our Facebook links. That helps us too, because obviously we get this message out. Watch for future education sessions. We've got more on the way. All right. Take care, everyone.